actually there is no treatment for improving fetal growth faltering. So we have to manage, and he mentioned how to manage the cases in an excellent way. First, we have to diagnose the IUGR. How diagnose? He mentioned in a such a way so that everyone is capable of understanding that. And
Madam, thank you, madam.
Okay, next.
Madam, thank you very much for your brief comment on the FIGO session. We are already running short of time. And now I am requesting Professor Sueda Saida for her to conclude the session and give vote of thanks.
Okay, thank you. Thanks to all.
Thank you, Professor Nasreen. All praises goes to the Creator, the most generous and the most merciful.
শোনা যায় না আপনার কথা?
শোনা যাচ্ছে না?
না, হেডফোন লাগান, তাড়াতাড়ি করেন।
যাচ্ছে, এখন তো শোনা গেল। বলো, জোরে বলো।
শোনা যাচ্ছে?
হ্যাঁ।
Thank you, Professor Nasreen. All praises goes to the Creator, the most generous and most merciful. It's my privilege to pay a vote of thanks to our honorable chairpersons for conducting the session so successfully. My heartiest thanks to our honorable speakers for their brilliant presentation, which enriched our knowledge and enlightened us enormously. I also must thank to our pharmaceutical companies who has supported us continuously to organize and to accomplish the session so nicely. I also must pay thank to our audiences to make the session a success. Now I am handed over the mic to other rapporteur of the next session, the RCSG session. Thank you all. Thank you very much.
রেশমা, শুরু করো।
Can start now.
Assalamu alaikum. Shall I start now?
Yes, please.
Okay. Respected chairpersons, expert panelists, and eminent keynote speaker, as well as all dear participants, Assalamu alaikum. Peace be upon you. Me, Dr. Reshma Sharmin, the rapporteur of the session, welcome you all to the 30th International Scientific Conference of OGSB RCOG session with the time-demanding theme, Let's Take Care of the Ovaries. In this session, we have three honorable chairpersons and the celebrated keynote speaker, Professor Nick Pane, an expert panelist from home and abroad. Now requesting Professor Shahin Rahman Chaudhry, Madam, to moderate the whole session.
Thank you, Reshma. Am I audible? Yes?
Yes, Madam, yeah.
Yes. Leaving behind 2 years of difficult journey at the beginning of 2022, we are still facing the peak of the third wave of this pandemic crisis. Although the mortality and morbidity are not alarming like before, but still we are facing some changes, movement are restricted. However, we are much more confident and experienced to face this unresolved war. Paying respect to the departed soul and wishing early recovery of those who are suffering, I'd like to start the session. Ladies and gentlemen, very good afternoon. This is Professor Shahin Rahman Chaudhry, Chair ISC Bangladesh. Welcome you all in the RCOG session of the 30th International Scientific Conference 2022 OGSB. Ovaries are the most important female reproductive organ. With its hormonal contribution, we represent ourselves as a female. It protects eggs, a female born with, and release eggs for possible fertilization, from where our family chain starts. Yes, ladies and gentlemen, theme of our topic is let's take care of our ovaries. May I now take the opportunity to introduce the chairperson of this session. We have three renowned gynecologists from home and abroad who are actively involved in women's health in different sectors. May I now introduce our chairperson? May I have the CV of Alison, please? Alison Wright, she is from England. She is working as a consultant ONG in the private Portland Hospital and also working in Royal Free Hospital in NHS. She's the immediate past Vice President of Royal College of Obs and Gynae, and currently she leads the personalized care of maternity at NHS England and NHS Improvement. And she is also the UK representative for FIGO Safe Motherhood, and her special interest is childhood trauma, urogynecology, pelvic floor dysfunction, menopause, and so on. Our next chairperson is Professor Saiba Akhtar. Madam was the past president of OGSB, and she is the national focal point of Fistula Center since 2005, and she's the chairman of Fistula Task Force and member PPH Task Force Bangladesh since 2007. And she's the Secretary General of International Society of Obstetric Fistula Surgeon from the term of 2012 to 2014. And obviously she is known as a Cybers method, which is the most important management in the PPH, that's the condom, uterine balloon, tampon. Our next chairperson is Nusra Jaman. She's been working in different hospitals in Dhaka, but presently she is working as a senior consultant in United Hospital, and her special interest is in infertility and gynecological endoscopy. It is my pleasure to introduce the keynote speaker of this session, Professor Nick Penny from UK, who will talk on premature ovarian insufficiency IMS latest recommendation. May I have the CV of Nick Penny, please? So Nick is working in the Queen Charlotte and Chelsea Hospital in England, and he's the professor of practice in Imperial College London, and he's president at International Menopausal Society and director of International Center for Hormonal Health. Thank you. And in the second part of the session, we have panel discussion, which is very interesting and interactive. And it's my pleasure to introduce our learned panelists from different parts of the world. I would not like to go through with the CVs, but I will just introduce the panelists, and probably when we'll go through the panel discussion, I will introduce them shortly. Thank you all my panelists. Sorry for waiting for a long time. Now, ladies and gentlemen, once again, I'd like to warm welcome you all in this RCAG session. With the permission of the chair, I'd like to start the presentation of the keynote speaker, Professor Nick Penny, who will talk on POI IMS latest recommendation. Obviously, because of the time difference, we'll be joining the recorded session presentation of Nick. Thank you. Please, may I have the presentation of Nick, please?
Gentlemen, firstly, a big thank you to the scientific committee for inviting me to address you on the subject of premature ovarian insufficiency, which I will derive from the latest International Menopause Society recommendations. I'm sorry that I cannot be with you there in person on this occasion. These are my industry and personal disclosures. So the recommendations will be largely derived from the IMS POI white paper of 2020. It was a privilege to work closely with IMS and my fellow experts shown on this slide to produce this position paper for World Menopause Day. We also produced materials for women, as shown here. All of these are free to download from the IMS website and translated into many languages. These are the information leaflets for women shown in greater detail, giving important information on what is POI, what causes it, what is the impact of this condition on health, how is it diagnosed, and what are the treatment options. Last year, we also published a special issue in October 2021 in the Climacteric Journal, containing a number of papers on POI, which I'm sure you will find to be of great interest, including a POI toolkit for primary care, co-published with EMAS. So premature ovarian insufficiency is also referred to as premature ovarian failure, premature menopause, or primary ovarian insufficiency. It is a clinical syndrome defined by the loss of ovarian activity before the age of 40 years. It is characterized by menopause signs and symptoms, cessation of ovulation or amenorrhea for more than 4 months, hypoestrogenism, and high serum gonadotropin levels. This is the first of the set of key recommendations on POI from the International Menopause Society, starting with demographics, etiology, and pathophysiology. Terminology and diagnostic criteria should be standardized to avoid confusion about the diagnosis. Full understanding of etiology and pathophysiology will facilitate our efficient diagnosis and management of this condition, for instance, using a global registry and biobank to log information. Global, ethnic, and cultural variations in prevalence and presentation do require clarification. POI may be either spontaneous or induced. Spontaneous POI is mainly due to idiopathic causes with no identifiable etiology, genetic cause, which is classified as either X-linked or autosomal dominant. It may also be due to autoimmune ovarian damage and infections such as mumps, oophouritis, TB, and malaria. And it may also be due to other infections such as CMV, varicella, and Shigella. Induced premature ovarian insufficiency is mainly due to iatrogenic causes such as bilateral oophorectomy, bilateral ovarian cystectomies, which reduce ovarian reserve, chemotherapy, radiotherapy, and pelvic embolization. There may also be an adverse effect from environmental factors such as cigarette smoking. The next set of recommendations is on the diagnosis of POI. Menstrual health and family history are vitally important in making the diagnosis, and the diagnosis should not be made on the basis of only one FSH level. AMH testing is only required if there is diagnostic uncertainty, and baseline DEXA scanning should be offered to all those diagnosed with POI. Timely diagnosis is vital, and delay and subsequent period of estrogen deficiency has been cited as a contributor to low bone density. Hormone therapy may not be sufficient to increase bone mass, and many lose BMD by the time of follow-up if diagnosis is delayed. So it is better to minimize initial bone loss than trying to catch up. These are data from our POI registry on duration to diagnosis from first presentation. And as you can see here, it can take an awful long time to make the diagnosis, even up to 7 years. These are data from our POI registry on bone density. And you can see for every unit increase in time, BMD as measured by spine T-score decreased significantly. So it's important that we make the diagnosis early. The next set of recommendations is on the management of POI. And the management should be multidisciplinary and include patient advocacy groups. Lifestyle, diet, and exercise should be optimized. And HRT should be advised at least until the average age of menopause, unless there is a contraindication. There are very few data for the benefits and risks of complementary therapies in this age group. Replacement can be with the combined pill initially, but in the long term, hormone therapy is recommended to optimize bone and metabolic health. One of the most neglected areas of POI is the psychosexual and psychosocial impact. Women with POI have a high incidence of psychosexual and psychosocial problems. So multidisciplinary teams should routinely offer counseling regarding psychosexual and psychological health issues. VVA and GSM symptoms should be inquired about openly and addressed effectively. And androgen replacement should be considered where sexual desire is low. There are multiple psychological effects of POI, including increased anxiety, depression, and somatization, reduced self-esteem and overall life satisfaction, and high levels of psychological distress in both users and non-users of hormone therapy. Moving on to cardiometabolic health. Women with POI should be informed about risk factors for cardiovascular disease and the importance of lifestyle changes. Hormone, lipid, and insulin resistance problems should be emergently diagnosed and treated individually and effectively. And hormone therapy is strongly recommended at least until the average age of the menopause, and in some cases the whole of life, in order to reduce cardiovascular morbidity and mortality. What about bone health in POI? Well, women with POI are at an increased risk of osteoporosis, and there should be comprehensive risk evaluation, education, and hormone therapy is recommended to prevent loss of bone. Specialist advice is needed for women where hormone therapy is contraindicated or where sustained fragility fractures occur early, even whilst taking HRT. Evidence gaps persist regarding the optimum regimen, and monitoring and fracture outcomes need to be monitored carefully, and this highlights the need for ongoing research. What about cognitive function and dementia? Well, data from studies in much older women, such as the WHI cognitive study, must not be extrapolated to women with POI. The cognitive study of WHI was in women with an average age of 67. A window of opportunity for cognitive benefit of hormone therapy when initiated within the perimenopause exists in POI, as it does for cardiovascular disease. Prospective randomized trials of dementia risk in women with POI, however, are unlikely to be conducted due to the need for very large numbers and long-term follow-up. And findings and outcomes in women after bilateral oophorectomy may differ from those with non-surgical POI. These are early data from our registry, which show that severe symptoms are more common in malignant POI due to the rapidity of loss of estrogen following iatrogenic interventions such as radiotherapy and surgery. The treatment itself for the malignancy can contribute to the symptoms. For instance, night sweats occur due to some of the chemotherapeutic regimens, and severe vaginal symptoms can occur due to graft versus host disease. One of the most important effects of POI is the impact on fertility. And infertility is certainly one of the most distressing aspects of POI. And there are no proven treatments yet to increase the rate of autologous oocyte pregnancies. When counseling women with POI about fertility options, they should be given correct information to empower them to make evidence-based choices. And oocyte donation currently offers the best chance of achieving a pregnancy in POI, although not everybody wants this, and it is not universally available. Loss of fertility was viewed by our POI population as one of the most problematic concerns of the condition in this survey conducted by Danny Singer. Sexual function and psychological effects also ranked highly on patient concerns. And there were even concerns about long-term use of hormone therapy, even though we counseled women that hormone therapy in POI was just putting back hormones that would have naturally been present. What about research priorities in POI? We need to expand our global POI registry, and I'm looking for collaboration amongst all of you who see patients with POI in your clinics. And we need to determine further the etiologies of POI, especially the genetic. We need to discover reliable biomarkers for predicting POI. AMH doesn't always predict whether POI is going to happen. And we need to look at the impact of hormonal interventions, such as pill versus hormone therapy, on all aspects of well-being and long-term health. The combined oral contraceptive pill is often seen as simpler and more peer-friendly, but as Jerry Conway said, it's driven more by practicalities rather than science, because some of these women still require contraception. It delivers a synthetic type of estrogen, ethinyl estradiol, not 17-beta estradiol, and if there is a pill-free week, then that allows for symptom resurgence. There have been small randomized controlled trials of hormone therapy versus a pill, 3 thus far, And even though the pill most suppressed FSH levels, HRT led to less hyperinsulinemia, increased bone formation markers, and improved lumbar spine density. And these are the data from Janice Reimer and Beth Cartwright's unit showing the increase in bone density that you get with HRT in green, stabilization with the pill in red, but loss of bone density in women not using hormone therapy with POI. And in the UK, we're about to embark on a multi-center trial looking at pill versus hormone therapy with bone as a primary outcome measure, but also looking at quality of life and long-term health. Further key research priorities in POI include the role of androgen supplementation, the differential impact and management of iatrogenic and spontaneous POI, understanding POI as part of an aging syndrome versus aging following POI due to hormone deficiency, confirmation of efficacy and safety of fertility-enhancing techniques, and further clarification of the role and division potential of human oligonial stem cells. This is a list of the national and international experts who have already agreed to collaborate on our POI registry project. And as I said earlier, I would like all health professionals looking after women with POI to contribute to this. Please do send me an email. I would now like to summarize the key take-home messages for healthcare professionals regarding POI. Irregular periods and menopause-type symptoms in women less than 40 years of age should be investigated promptly in order to facilitate timely diagnosis of POI. Reliable diagnosis of POI requires at least 2 elevated FSH levels 4 to 6 weeks apart so that we get the diagnosis right, and an anti-Müllerian hormone test is required where there is diagnostic uncertainty. The etiology of spontaneous POI remains uncertain in many women, but is probably genetic in origin. Women with POI have a high incidence of psychosexual and psychosocial problems, and we need a multidisciplinary approach to adequately manage these problems. And it's vitally important that these young women continue their hormone therapy, if they can, at least until the average age of the menopause, to maintain their quality of life and to protect their bones, their heart, and their brain function. And infertility is one of the most disturbing aspects of POI, and there are no proven treatments to increase the rate of pregnancy with autologous oocytes. So oocyte donation remains the best chance of pregnancy. So further research is required into the diagnosis, etiology, and optimum hormonal and fertility management of these young women. So with that, I'd like to thank you for listening, and I will leave you with some key references, which I would be very happy for you to be provided after the meeting. Thank you very much for your attention.
Thank you, Nick, for your excellent presentation on POI-IMS latest recommendation. You have highlighted about the standardization of terminology and diagnostic criteria so that there is no confusion comes. You also highlighted how we should take the history to diagnose, and also you focus on not just focus on one single FSH level, need to do 4 to 6 weeks apart another one, and also you mentioned when we should do AMH as well. And most importantly, what you highlighted is the multidisciplinary approach, because these sort of patients do suffer from psychosexual and psychological problems. So it's very important to deal with this patient. First of all, we need a multidisciplinary positive drive effort. Thank you once again. May I now request, before I'll like to, this is for the audience, please, if you have any question, please do use the chat box and we'll try to answer accordingly. May I now request Professor Alison Wright to give your valuable opinion or remarks about Nick's presentation. Alison, please.
Thank you so much, Shaheen, and I'm delighted to be here amongst friends I'm delighted to be here amongst my friends in Bangladesh. Hopefully next time we will meet face to face, but it's great to see everybody anyway. Yes, Shaheen, I would absolutely echo what you said about my dear friend and colleague, Professor Nick Panay, for an excellent lecture and a really exciting overview of all the research and the diagnosis and the management actually of POI. I'd also like to say how pleased and honoured I am to be sharing the platform with Professor Saiba Akhtar and Professor Nusrat Zaman as my dear chairpersons, and to be here at the 30th International Scientific Conference. So ovaries are very important. I'm very glad that you've chosen this important topic, and also to recognise the work of the International Menopause Society in this regard. People are talking about menopause now, including premature ovarian insufficiency, I think much more than we used to. And I think it's really important that Nick Panay has highlighted the importance of diagnosis in recognising the concerns of women. I've certainly seen women before who've been told by another doctor, you can't possibly be in premature ovarian insufficiency, you can't possibly be in menopause because you are too young. And I think one of the key messages from Nick is that we really need to listen to women and what they're saying. I think also something extremely important, as well as that diagnosis, is to look at the implications in our long-term health. Nick Panay has talked very clearly about the importance of recognising osteoporosis, getting a baseline bone density scan, and ensuring that these women do not suffer from more bone density issues, more cardiovascular issues than they need to, because this is a long-term health. But of course, their own concern is fertility. And as Nick has said, we need to do much more research into this area of what we can do once we've diagnosed POI. What can we do to help these women in this very difficult, distressing situation where, of course, they are worried about their own fertility. So I think the reasons for continuing research in this area have been very well outlined by Nick, and I'm sure he'll be delighted, and I'm sure there will be many people on this call who would like to collaborate with Nick and with the RCOG on this very important topic. Thank you so much, Shaheen.
Thank you, Alison, once again for your very excellent and informative remark. So I'd like to move on to the second part of the session, which is the panel discussion. So my first, may I now have all the panelists list, please, in front of the screen, please. Technical support, please. Anyway, yeah, okay. So my first question is to Dr. Samsud Zohar. He is from Fortis Hospital from Calcutta, India. Dr. Samsud Zohar, as you understand that the POI patient, because of their uncertainty about the illness, they do suffer from depression, they have anxiety, they do have very low positive drive and always towards the negative attitude. At the same time, they have physical changes, which is significant for them and it's needed treatment. So may I ask you, what is the optimum hormone therapy to maintain the quality of life of these women apart from infertility? Dr. Samsud Zohar, please. Dr. Samsud Zohar, please. Dr. Samsud Zohar, are you there?
Proceed, and I'm calling him. You can proceed for the next.
Okay, I'll go with the next one. My next question is to Dr. Tanzim Sabina Chaudhry. Are you there, Sabina?
Yes,
Dr.
I am.
Chaudhry? Yes,
Yes.
thank you. As an infertility specialist, you have seen a lot of women coming to you for infertility treatments, but they have been already on the ovulation-inducing drugs for a long time. A lot of time you have seen this using these ovulation-inducing drugs was not very judgmental. So keeping in this mind of our discussion, what do you think, how we should protect our ovaries from injudicious use of ovulation-inducing drugs?
Thank you, Professor Shaheen, and thank you to the Scientific Committee of the 30th International Conference. This is actually a burning issue, and I'm dying to talk about it because we face it every day in our day-to-day practice. Most of the cases, what we see that most of the patients, in case of infertile patients, ovulation induction is started even without excluding other factors. And unfortunately, sometimes male factor is not also excluded. So I think the number one rule should be before starting ovulation induction, we should exclude the basic problems that may be present in both partners of the couple, especially male factor, before starting ovulation induction. Second is that when we start ovulation induction, especially in a low resource country like that, it's sometimes difficult to monitor. But it's very important to know that if you start ovulation induction, especially with gonadotropins, it's very important you have to monitor by transvaginal scan. In case of oral drug, you can use it, but but it's better that you do 1 or 2 cycles of monitoring before giving the drug for a long period of time. And we should always start the ovulation induction with the lowest dose and start according to the transvaginal scan report. And we have to remember that there is a certain maximum dose of every drug. So if the patient does not ovulate with that maximum dose, it's better that we stop the drug. In that case, we have to find out whether there is any other condition that is causing the patient not to have proper ovulation. Another thing that we get to see is that multiple therapy. We get to see therapy with multiple combination drugs. We usually call them cocktail therapy. But is there any need for giving multiple drugs for ovulation induction? It's very important. There are protocols where you can use oral and injectable drugs together, but sometimes we even get to see multiple oral drugs together for ovulation induction without any ethical or scientific basis. So we have to remember that starting a protocol, we have to stick to the scientific protocols, and we cannot actually combine all the drugs together. Another thing is that if the patient is ovulating, still we can give ovulation induction. That would be for unexplained infertility, but that's the maximum for 6 cycles. We cannot continue the drug for more like the indefinite period of time. And there's another practical thing is that when the patients come to us, they usually visit different centers, as Professor Shaheen has said, and all of us start with ovulation induction. That's not right, actually. It's very important that we go through the previous documents and to find out the age of the patient and how long she's been infertile and how long she's been having and what drug she's been having. So we cannot all start with ovulation induction. If she has had enough ovulation induction, it's better that we formulate the next plan. So lastly, I want to say
you, Tanzim. I just wanted to ask, because we are very concerned about using these sort of drugs. Is it going to affect on the POI, lead patient to POI, if you're using indigenously? Obviously, I think because if you're using not required, what do you think? My main concern is I like to know from you, if you use indigenously.
Okay, so if you look at the evidence, there's not, as you can see from Professor Nick's lecture as well, there's no actually a clear connection between ovulation induction and premature menopause. But we have to remember that we have to customize, like not all patients are same. There are patients with low AMH, there are patients who are advanced age, and those patients who had already had multiple ovulation induction. In that case, very important that we find out that there's no point continuing the ovulation induction for a long period of time. It can lead to early menopause.
Because of the shortage of time, thank you, Tanzim. So I think I get the message from you that we should have a standardized protocol, especially at the primary level, before they're going to specialist, isn't it? Thank you once again. So may I now ask Alison as a panelist, please? There's a question for you. As you know, the POI patient dealing with is very difficult and challenging, not only for the women, for the gynecologists as well. And there are various explanations in the literature, but nothing has actually focused about the etiology. We know that, and Nick has already mentioned. So however, there are certain factors about the environmental factor. We know that it may lead to ovaries to come premature sort of menopause. So can you tell us, please, how we can protect our ovaries from environmental pollution? Alison, please.
Thank you, Shaheen. Yes, I think this is a very challenging area, actually. As Professor Nick has already told us, it's difficult to know the etiology, and it's probably genetic in many cases, those that are not obvious, iatrogenic, obviously. There's not very much in the literature regarding this. It is intuitive to us that pollution may harm our ovaries. We do know of other things that may harm our ovaries, but actually there's very little evidence. So there's some research done in Korea where they looked at 2,000 women and they did look at the particulate matter, and they did find some evidence there of damage, potential damage in terms of ovarian reserve to women. But these reports are very few and far between. Regarding the effects of air pollution generally, we have some impact on low birth weight from South America. We have some impact on placentation from other places, particularly Belgium and Europe. But regarding the ovaries specifically, we have very little information. And for that reason, at the RCOG, we are developing a scientific impact paper, as you all know, for those areas where there is not very much evidence, to do a scientific impact paper and look at what the effects of climate change and air pollution could be on our ovaries, because it is very difficult to exactly know. And as we all know, it needs very big numbers to show a difference in terms of ovarian reserve and therefore on fertility. But I think it's something we do need to know. I'm very pleased that our president of FIGO, Jean Connery, has a big interest in climate change. And I'm sure we're going to see much more research done in this area. I think in the meantime, what we can do is just all of us try and work on climate change in any case. I think it's our duty for many reasons, our children's asthma as well as our own ovaries. And I think it would be very valuable, the more research that we can collect to really demonstrate what the actual impact is on our ovaries specifically. Thank you, Shaheen.
Thank you. Alison, I just wanted to ask you, do you think the plastic, there are concern about don't keep the plastics in the car or in the house. Do you think it has got effect on the ovaries as well as passive smoking? I know smoking, the girls, if they're taking, there is a chance of premature, but what of the passive smoking or the plastics? Have you got any idea or any thought about it?
Yeah, we have very little evidence on it, Shaheen. I mean, I'm sure you all know on this call that when we do see women in this very distressing situation, they do ask, is it because my father was a smoker, or is it because of this and that? And I don't think we have those answers. I don't think we have robust evidence yet to tell women, but it does make sense for so many reasons on our health benefits that we reduce smoking, reduce plastic use. So I think we need to be doing it anyway, as well as collecting the evidence. But for the individual woman that's talking to us, I don't think we have robust evidence enough to give that answer.
Thank you, Alison. Is Dr. Samsujah is around now? Dr. Samsujah? Okay, may I now just go to Dr. Bhaskar Pal? Are you there, Bhaskar?
Yes, I'm there, Shaheen.
Yeah. Hi, how are you?
Hi.
Bhaskar, surgery is always related to endometriosis. It is a very difficult and challenging, and there are times you do see patients, they face a lot of time, maybe more than one time surgery. And we always know when we are involving with this endometriotic surgery, our focus should be on the preservation and not to disturb the ovarian reserves. So from that point of view, what do you think from your point of view suggest, what are the tips and tricks we should follow when we are doing this sort of surgery? Bhaskar, please.
Thank you, Shaheen. Before I start, I want to thank OGSB for inviting me here. And it's great to see friends, not only from Bangladesh, but from UK. Great to see Alison. And it's great to be invited by Shaheen, because Shaheen and I go back 25 years. We were colleagues in London 25 years back. Shaheen, I will take a step further. I will not only talk of endometriosis surgery, I would talk on ovarian surgery as well, although the main bit is the endometriosis surgery. Okay. Now, even when we are not operating on the ovary, but we are operating on the tube, sometimes we can disrupt the blood supply of the ovary. So I would start with that we need to be careful when we have a young girl a case of an adnexal torsion. And the current teaching is detort and do not remove anything. That's I think, very important one. Anytime we are doing a salpingectomy, we need to use something like a bipolar energy and stay as close to the tube as possible, or an ultrasonic energy, so that we do not disrupt the blood supply to the ovary. Another situation where we've seen previous premature ovarian failure is when people have attempted doing a laparoscopic ovarian drilling. Now, people are very tempted to do a drilling when they do a laparoscopy and find cystic ovaries. But we need to be very, very judicious about doing it and stick to doing 4 punctures or 5 punctures, depending on what wattage of current we are using. And maybe a good practice is to cool the ovaries in a normal saline immediately after doing that. But making 15 to 20 punctures in an ovary for, say, 5 or 6 seconds each would be a recipe for disaster. Finally, coming to endometriosis surgery. I think endometriosis surgery, we all understand that there are 2 ways that we can primarily operate on ovarian endometriomas. One, we can do an enucleation of the cyst. If you do an enucleation of the cyst, there is less recurrence and more relief of pain, but there is definitely more destruction of the ovary. But the issue is that there's no consensus whether this destruction of the ovary will necessarily lead to poorer IVF outcome. But it is important to make sure that we attempt not to damage the ovary. So when we are doing a cystectomy, the aim is to stay in the correct plane, number one. Number two, minimize the use of energy sources. Most of this bleeding will stop if you're in the right plane when you are irrigating, and you do not need to do any kind of energy sources. If I know that laser is very popular in the West, but access to laser is limited in our subcontinent. The other thing is we are very lucky to have vasopressin in India. So if you're in doubt, that you can inject vasopressin in between the cyst wall and the ovary, and that will relieve the bleeding. That is number one if you're doing an ovarian cystectomy. For smaller cysts which are less than 3 centimeters, what we do is we drain the cyst and we irrigate it, and then we do a surface coagulation either using a bipolar diathermy or a laser if somebody has an access to laser. Now, we have to remember that this causes less ovarian damage, but there is also a higher risk of recurrence. So essentially, we need to decide why we are doing the surgery. If we are doing it primarily for pain, and this is the first time surgery, then enucleation is a better idea, provided the ovarian reserve is intact. If the ovarian reserve is poor and pain and fertility is the main issue, then either we should proceed with ART or we should do a drainage and coagulation of the ovarian cyst. In young patients with very large endometrioma, I think we need to offer them a possibility of an oocyte freezing before we take them for surgery if the ovaries are accessible. Lastly, there is another method which is propagated by Jack Donis, which we can do for very large endometrioma, where we do an enucleation of the cyst till we come to the hilum. Hilum is where the maximum ovarian damage will happen. And so when we come to the hilum, instead we stop the enucleation, and with cold scissors, we cut the edges of it and do a surface coagulation. And they have shown in very large endometrioma, with this, they have achieved very good pregnancy rates and doesn't cause ovarian damage. So these are the essential points that we need to understand. And if it's a recurrent endometriosis, we need to pay attention to what is the ovarian reserve and be judicious about where we are attempting to do. Thank you.
Thank you, Bhaskar, for your wonderful suggestion. Whatever you said, it's so basic and simple. We know about it, but what I can understand that before you plan for surgery, we should have a good plan. And I think one of the important things as a gynecologist, we should have a very good knowledge about the anatomy where we are working, that we need to focus. Thank you, Bhaskar, once again. So now I'd like to ask Professor Mariam Faruqi. Are you there, Mariam Faruqi? Professor Mariam Faruqi? Are you there? Professor Mariam Faruqi.
Yes, Dr. Shaheen.
Yeah. Okay.
Assalamualaikum.
Okay, Mariam Faruqi, I'd like to ask you, because we just discussed a couple of things like about surgery related to ovary. We discussed about how we can protect ovaries from environment, and also Tanzim also discussed about the indigenous use. Just coming out from their very simple question, I'd like to ask you, is there any way we can well ahead predict that this ovary is going to compromise or is compromised?
Thank you, Professor Shaheen, for including me in important issues of discussion. I am honored to be a part of this panel. Respected chairpersons and dear colleagues, very good evening and assalamu alaikum. And Professor Shaheen, regarding your questions, Neat Penny has described very fantastically everything. The POI is a disorder characterized by amenorrhea, estrogen deficiency, and elevated gonadotropins level. So, and he also described about everything about the causes, what are the causes, idiopathic, chromosomal, genetic, infection, autoimmune, and everything very nicely. And it's very challenging when a POI is established. It's very challenging to treat. And we have, and for diagnosis of POI, usually a patient, or whether her ovarian reserves are becoming poor, usually patient come with most common presentation is irregular menstruation following after irregular for few years, she became totally amenorrhea. Or it may be a primary amenorrhea, and then there is the sign symptom of estrogen deficiency. Usually it is hot flashes, night sweats, mood swings, fatigues, depression, anxiety, decreased libido, dry vagina, vaginitis, and dyspareunia. And in the long-term effect, we found she developed cardiovascular disease and osteoporosis and repeated fractures. So with the symptoms, we can, after doing investigation, we come to a conclusion that it is a case of PY, but by the time it established so much, the difficult to treat, difficult challenge for us, and especially also for regarding her fertility also. And in the screen, for screening, we have to also look for whether she has any thyroid problem, type 1 diabetes, or Addison's disease. And very important is whether she had, in the history, we have to take whether she had undergone chemotherapy or radiotherapy or any difficult, what Dr. Bhaskar described, difficult pelvic surgery. This may also lead to poor ovarian reserve. So this all comes into the account during the diagnosis of poor ovarian reserve. And we all know that in familial history, we have to take the history from mother, whether she had premature ovarian failure or her sister suffering from the same. And most important is idiopathic, where 60 to 80% is an idiopathic course, while difficult to make a conclusion or come to a diagnosis. And sometimes, what good is, sometimes the idiopathic may reverse, and there is even 5% pregnancy of this idiopathic POI cases.
Thank you, Professor Mariam Farki. Basically, what you address is the history. With this part, a lot of time we don't concentrate much, but it's a very holistic way of taking history. It's very, very important. Thank you once again. I was planning actually to get a comment from our chairperson. So may I now request Professor Saiba Akhtar to have some comments about the discussion we have so far. Please, Professor Saiba Akhtar.
Thank you, OGSB. Thank you, Shaheen, for inviting me here. It's a great pleasure to see the friends like Ellison, Bhaskar, and hearing from our very outstanding speaking panelists. First, I like to comment about what Tanjin Sabina said. How to protect the ovary from injudicious use of ovulation-inducing drugs. This is a common thing which we have seen, and she really nicely told about the scientific basis should we think about, and whenever a patient comes to see whether she has any ovulation-inducing drug before, because this patient goes from one person to another, and so that should be seen, and then formulate the next plan. And definitely, if there is a low AMH, she told that she should be planned for ART, and also the patient age is also important. Thank you, Sabrina, for your nice comments and about these questions. Now I will come back to my friend Bhaskar. Bhaskar actually told about what can be done if there is a surgery for ovarian endometriosis, how to take care of the ovaries, even not only the ovarian surgery, but if you have any surgery on the tubes, when you do for ovarian drilling, we should take judicious care about the ovary, and for that he suggests that if possible, where it is available, to use the laser vasopressin and cold coagulation. And if the cyst is small for the drainage, and also he also told important thing is also freezing if there is if it goes for the ovarian cystectomy. I like to thank Bhaskar, for your excellent comments and guidance for our, especially for our young gynecologists.
Thank you, madam.
Now I come to, thank you, Bhaskar. Now I come to Mariam Faruqi. How can we predict whether he has poor results? Mariam Faruqi has gone through the histories, the chemotherapy, surgery. The family history is also very important, and the symptoms, so many have irregular bleeding or menstruation, and also investigation. Thank you, Mariam Faruqi, for your nice comments and suggestions.
Thank you, Appa. Thank you, madam.
Okay, thank you, madam. So now I'd like to ask my question to Professor UDP Ratnasiri. He is from Colombo, and he's working in Castle Street Hospital in Colombo, and he's the chairperson ISC of Sri Lanka. So, sir, I have a question to you. As a gynecologist, as you know, the first platform for the patient is to see us with a gynecological problem. And obviously, accordingly, they are referred to different disciplines like subfertility, oncology, medical oncology, etc. So in that point of view, I think it's very important. In fact, it's very essential in all these disciplines to have basic training, especially when the issue is coming, how to protect the ovaries or ovarian reserve or tissue. So I'd like to ask you, sir, so how we should actually set up a training program for ovarian tissue preservation before surgery, before chemo, before radio. Thank you, sir.
Thank you very much for giving me this opportunity. Yesterday I was with you with another program. So this is actually challenging, really, because as you said that it is before surgery, before chemotherapy or some kind of radiotherapy. So we have faced situations that we have to preserve in the oocytes or the ovarian tissue. So this involves mostly surgical procedure as well as the embryologist thawing, freezing and vitrification kind of procedures. So as general gynecologists, now, the number of reproductive endocrine and infertility specialists are very minimal in our city, in the countries. So I think general gynecologists, they should have a basic embryological knowledge about the ovarian functions, how the ova are produced and how the fertilization are. These are very important basic knowledge, as well as they should have a basic or actually advanced training on laparoscopic surgery, because some of these ovarian tissue preservation is done with retrieving ovarian tissue and then taking out the cortex and then preserving with the thawing or freezing. So, and then again it comes after chemotherapy or radiotherapy transplantation into the other ovary or the same ovarian site or another heterotopic area. So this involves microsurgery as well as laparoscopic surgery. So in this procedure, we should not damage the ovary, as well as we should get the better part of the ovary from this preservation. So when we need to train our gynecologists, it is multidisciplinary actually. They should know embryology, they should know how to do the laparoscopy, as well as how to retrieve the tissues. So all these are important aspects. So it has to be led by the embryologist, geneticist, as well as some experienced surgeon. So the basic knowledge is needed, and then surgical expertise needed. So that takes time. And there have been several occasions the ovarian tissue is retrieved and preserved and then transplanted into the other ovary or into another site that is called heterotopic or autotopic transplantation, and successful pregnancies have been achieved, maybe natural or maybe artificial reproductive techniques with the in vitro fertilization. So this is really an advanced gynecological field in the reproductive field. So it needs some kind of it takes some time to learn, and it is the learning experience and learning curve is a little longer, because it involves not only the simple laparoscopic surgery, it is involved in the microsurgical procedures also. And it cannot be done alone with the gynecologist. You need the embryologist to take the cortical tissue and then thawing, freezing, And once the therapy is, completed, whenever they need the fertility issues, then to reimplant. So those are issues, I think, needing some kind of expertise. I think, the general gynecologists need some kind of training. So we don't have this kind of, modules or training programs in our general obs and gynae. So it's mostly involved in the reproductive as well as infertility area. So many training centers in our areas, especially in our countries. So they have to get this training in specialized centers and then come and start in our areas. So that is the situation. So other than the ovarian preservation, we have the oocyte preservation. So that is mostly for pubertal patients, and this ovarian tissue preservation is mostly for pre-pubertal patients, because that is before the chemotherapy or the radiotherapy or whatever, they can preserve the ovaries. So those are the issues, and it is a highly advanced field, I would say. Thank you.
Thank you, sir. But I was thinking you could mention about my interest was actually for the basic as a gynecologist, because we need to build up gradually when somebody is going to subspecialty. So we should be really focusing on the gynecologist to do basic laparoscopy. They should have good understanding. I think this is very important to train all the gynecologists as a compulsory thing. I think we should focus on training. Anyway, thank you very much. Thank you for your excellent suggestion and discussion about that fact. And so may I have my last panelist, Samsid Johar? Is he here? Dr. Samsid Johar, are you there? I think he's not there, but if he comes, we'll take on. But now I'd like to request Professor Nusrat Jaman to say a few words about the discussion, as well as just wrap up the session, please. Professor Nusrat Jaman. Professor Nusrat Jaman. Madam?
Am I audible now?
Yes, madam.
Okay, thank you, Shaheen. Thank you, Professor Shaheen. In fact, I should thank the scientific committee of the 30th Scientific Conference of OGSB to give me the opportunity to be a chairperson in this very prestigious RCOG session, where the theme by itself emphasizes the role of gynecologists to save the ovaries. And it also emphasizes the integral part of the ovary as a unit, which is important in the life of the woman, whatever be the age, be it at puberty, be it at adolescence, reproductive age, perimenopausal age, and also after the menopause. As we all know, the impact of premature ovarian insufficiency has far-reaching consequences due to its impact on general, psychological, sexual quality of life, fertility aspects, and long-term bone, cardiovascular, and cognitive health. So first, I would like to thank the keynote speaker, Professor Nick Kenny, who made an excellent deliberation, and he highlighted, and we were indeed privileged to know that he's a member of the International Menopause Society and has been working as a group to improve the concept of premature ovarian insufficiency, and highlighted on the genetic, environmental, the other factors. And we are privileged to know about the details and all the steps that are being taken by the International Menopause Society on the genetic, environmental, geographical variation. And he also emphasized on the timely diagnosis. Actually, some of the panelists, I was very much engrossed in the deliberation, excellent deliberation of the panelists. The timely diagnosis and timely intervention will definitely save the lives of our mothers. So to highlight a little on Dr. Professor Ratna Siri, he has emphasized the role of training. Actually, the training should be universal to all the gynecologists regarding the importance of the ovarian function preservation. So he also said something about the oocyte preservation and also to build up the training programs regarding the surgery, the anatomical aspects which should be kept in consideration. The tertiary level definitely will do the oocyte preservation, the cryopreservation, but the basic techniques of ovarian preservation, ovarian tissue conservation during any laparoscopic or laparotomy, what we encounter, that should be kept in mind. We encounter a large number of ovarian endometriomas. So the technique of removing the cyst and also using less amount of electrocoagulation, just with the idea of preserving the viable ovarian tissue, is also very important. So we have enjoyed the panelists' discussion, and in conclusion, I know we have got another panelist. I don't know whether we will listen to him later on, but in conclusion, I will say that it is hoped that a global task force will subsequently be convened in order to formulate a consensus statement across key societies to accelerate data collection and analysis of a global POI register to facilitate progress in the key defined areas of research. Further research is required to assess the optimal regime, dose, or route of administration of hormone replacement therapy in women with POI. And in addition, national and international databases as the POI registry allow better understanding and management. Overall, I would like to say that let us all work as a united force, and I'm happy to know that the International Menopausal Society has taken this aspect very seriously and are working on training programs on evaluation of the severity of the condition with the idea of preserving the ovaries. Thank you.
Thank you, Madam, for your excellent, very valuable remarks. And you have actually overall covered the whole bits we have discussed so far. So we're almost at the end of our session, but I'm still looking for Dr. Samsudjah. Are you there, please? Dr. Samsudjah? I think he is not attending. So this is probably a very end of our session. I'd like to thank all the chairpersons. Now I'd like to hand over the mics to Dr. Reshma to give the vote of thanks. But prior to that, once again, on behalf of our COG session of 30th International Scientific Conference 2022, OGSB, my heartiest thanks to all the chairpersons, panelists, and the audience for giving time and your presence enrich our scientific session. Thank you. Reshma, to you, please.
Thank you, Madam. It is my immense pleasure to thank honorable chairpersons and expert panelists for having comprehensive discussion. My special thanks to celebrated keynote speaker, Professor Nick Panay, for delivering incredible presentation on this distressing condition, especially the key priorities in research area. We are really hopeful that this will boost up our enthusiasm to plan future prospective randomized clinical trial to determine intervention strategies. Eventually, we are really keen to work together to enrich global POI registry by starting our own national registry to facilitate POI research as well as biobanking. Finally, I'd like to thank Professor Shaheen Rahman Chaudhry, Madam, for her excellent moderation of the session, as well as pharmaceutical companies to organize this session. Again, thanks to all of you. Have a good day.
Thank you.
Shaheen, খুব ভালো হয়েছে। Thank you. খুব ভালো হয়েছে।